All right, guys, so let's begin. So we'll be discussing some updates. Yeah. So don't worry, I'll be sending this PDF to all of you, those who are in the group. Yeah. So, guys, we'll go through these stations quickly. Yeah. So, the first scenario that we have, I just want to have your opinions as well. I would like to make it more of interactive one, and I would like you to answer in the chat box as well. So, we have got a scenario. The patient has made an appointment because patient is requesting antibiotics because patient is traveling to a country, traveling to Thailand, for example. So, are we going to give antibiotics prophylactically to a patient? You know, last week, you know what happened? I was one of the candidates was discussing this scenario with me, and the candidate started like, "I'm not gonna give you any antibiotics when you're traveling." See, the thing is, any station when patient is demanding anything, for example, this patient is demanding antibiotics, or maybe a patient of viral infection demanding antibiotics, or a patient of normal tension headache demanding the CT scan. Do not deny it in the beginning itself because you don't know the scenario. The patient might be having some red flag symptoms there, which might be the indication of giving antibiotics, for example, in this case, right? So if patient is demanding antibiotics, what you're going to do, you need to ask which country you're traveling to, if you have done the vaccination or not, who else is traveling. You need to talk a bit about the insurance, if they have got travel insurances or not. Now, usually in the UK, we do not give any antibiotics. However, if your patient is immunocompromised, so if your patient is immunocompromised, if the patient has got any GI issues, patient has got diabetes, cancer, sickle cell disease, in these cases, you might be able to give prophylactic antibiotics to the patient as well. So yes, in the exam, patient is saying, I want this antibiotic. So what you need to do, I can see you are here for antibiotics. Let me ask you some questions to see if that's the best option for you or not. And then what you do, you will start taking the history as well, right? And then see if the patient has got anything like any state, any immunocompromised state if the patient is in. If that is the case, you might be able to give antibiotics to this patient. Yeah. Another thing, sometimes you might be going for standby antibiotics as well. What is this standby antibiotics? So it's usually given where the access to the medical assistance is poor, right? So there we can give standby antibiotics as well, right? For example, you're traveling to an area. For example, you are from a media house and you're traveling to a country where there is a war situation and you have to cover that particular thing. So yes, maybe standby antibiotics might be given in those scenarios, right? So my advice in this station, anybody requesting, demanding something, don't deny it in the beginning itself. Get the understanding. See what the scenario is. Take a bit of history. Whatever scenario is, there's a bit of history involved. Remember, 8 minutes, first half of the scenario, you gather some information. And then last 4 minutes, you give some information to the patient. So that should be your main aim. Yeah. Okay, then metatarsalgia, Morton's neuroma. It's been coming for a very long time, right? So easy scenario. Just one thing, remember, there are some clinchers there. Patient is working in corporates and she is, or patient is working in corporate and the patient is wearing high heels. That's the main thing, right? And patient is having pain between second to third metatarsal. So here, have a look at this picture. This picture will make your life easy. The patient has got pain somewhere here, right? So what's the risk factor? It's wearing tight or pointed high heel shoes. That is the main reason patient will have pain here, right? Now, what I would like you to do, any rheumatology scenario, you have to take a bit of history. Patient has got pain. So what you're going to do for pain? You are going to do the complete Socrates, right? Do the Socrates. See if the pain is only in this leg or the other leg as well. Ask about any fever, for example. So I just want to know if there is any septic area, septic joint, for example. Ask for any redness, any swelling, any bruising, any numbness, tingling. Because if the patient has got Morton's neuroma, the patient might have a bit of numbness in the fingers as well. So that is something that you can ask. All right. The treatment is simply, it's a price, painkillers, rest, Ice compression and elevation. That's the main part in the treatment as well. And definitely, what is the reason patient is wearing high heel shoes, high heels? I mean, so tell the patient not to wear that. So that will be your part of management, right? Now, somebody's asking about the vaccination in traveling. Okay, so the thing is, for the vaccination doctor, it takes time. For example, what happened is you have to tell your GP at least 6 to 8 weeks in advance that you are going for this vaccine. I mean, you're going to that particular country, so they will be able to go with this vaccination and all, right? So contact your GP or practice nurse, but at least 6 to 8 weeks in advance. Yeah. And vaccinations are freely available, but some vaccination you might have to pay as well, right? How to differentiate between Morton's neuroma and plantar fasciitis? See, where is pain in Morton's neuroma? As I showed you this picture, second to third metatarsal somewhere here, and this patient is wearing high heels. That's the main thing, right? Plantar fasciitis, one very simple thing. This patient will tell you, when I wake up in the morning and I put my feet on the ground, first time I get pain. So what is plantar fasciitis? See, this is your fascia, right? So this is the ligament which is connecting your toes with the heel. So when there is an inflammation of this part, this is what is known as plantar fasciitis. So I think when I do the proper Socrates, when I elaborate my presenting complaint, I will be able to differentiate it very easily, whether it is Morton's neuroma or Morton's metatarsalgia, or it is plantar fasciitis, right? Patient is saying, doctor, when I wake up in the morning and I put my first step on the ground, I feel pain. Close your eyes and say you have plantar fasciitis. That's the main thing. Right. The treatment is again painkillers, protection, and the ice compression and elevation, same thing, right? We can go for later on corticosteroid injections as well. Now, as the patient is having pain down there in the heel, so what we can advise the patient to do for wearing comfortable shoes as well, some supportive, non-supportive footwears and all, that could be quite helpful as well, right? So I think it's easy to differentiate between these two, Morton's neuroma versus plantar fasciitis. Yeah. Okay. Hyperhidrosis, we haven't seen for a very long time in the exam. And don't worry, there's a detailed video already on the YouTube, so you can have a look if you have to. Now, this station, let's go a bit more into this riluzole. I think you have seen in the last few exams, this station has come again and again. Patient is requesting for riluzole for motor neuron disease. When the station came the first time, the patient, how can I help you? And the patient started saying, doctor, I want riluzole. Now, the thing is, it's a bit difficult for us to find out, I mean, what is riluzole? I don't know. So the thing is, if you get something new, a new medication in the exam, which you have never heard of, what you should do, in every single room, what you'll have is a BNF, British National Formulary. So what you do, you go in and have a look. You open the book and see what riluzole is, and then you'll be able to answer the patient's concern very easily. Yeah. The task is your FI2 in a GP surgery. Patient is 57, has booked an appointment to see you. He was diagnosed like 8 months ago with ALS, amyotrophic lateral sclerosis, which is a motor neuron disease. And patient, he has been following up with the neurologist every 3 months. He's requesting a medication called riluzole. Talk to the patient, assess him, and address his concern. So now I think somebody asked me a question about follow-up also. So if a patient comes on follow-up, how should I be managing these cases? Right. So how can I help you? I want riluzole. Okay. Then I would like you to use the information that is given to you in the question. Right. So you can say, I can see from the notes that you've been diagnosed with a motor neuron disease, which we say amyotrophic lateral sclerosis, and that was 8 months ago. Am I right? Yes, doctor. So if you do that, it feels like you have come prepared. Patient will feel more happy with you. Right. Now, what you can do is you can ask the patient what the patient knows about this motor neuron disease. How much do you know about ALS? What treatment has been given? Because this patient is requesting riluzole, but what you need to know, what patient has already been taking, what is the treatment that has been given to this patient? Yeah, how much this patient knows about riluzole, from where he got to know about riluzole, and why the specialist didn't start him on riluzole, isn't it? So all those questions you can ask. Now the patient has got motor neuron disease, so I would like you to ask some questions about motor neuron disease as well. For example, like how's your speech, any weakness in any part of the body, any like grip, weak grip, muscle cramp. So all those questions, what you can do is you can ask. Can we read the part while taking the history from the card? So yes, so the information, the task you'll be having outside the cubicle, and what happens is when you enter into the cubicle, you'll have the same paper in the cubicle as well. Can I see the task again? Can I see this card again? Of course, yes, no problem at all, right? Now, what is this riluzole? Are you going to start the patient on riluzole? See, riluzole, this medication is prescribed by a specialist to slow down the progression of the disease. It can extend the survival and delay the need for breathing support. But the thing is, we cannot give this riluzole to every patient because we have to be very, very careful because it can affect your liver, it can affect your lungs as well. So what we do, what the specialists do, we always go for liver kidney function test and we do the chest x-ray as well. And if everything is okay, we may be able to start the patient on this medication. And we are not the one. It's usually started by the specialist, right? Because, this riluzole can cause a pulmonary fibrosis. So we have to see the lungs before we start this medication. We have to see benefits are more than the side effects or not. Yes, if benefits are more, only then we will start. Because every drug comes with side effects as well. So if the side effects are more, then what's the point of starting it? There is no point. So you have to be very, very careful. So remember, it can affect your liver, your kidney, and it can affect your lungs, can cause pulmonary fibrosis as well. So before we do it, we always do liver kidney function test. We always go for chest x-ray. And if everything is okay, then only we will be able to start. So that's what happens in riluzole. Right, next one is Huntington's. Yes, this comes also very often. So there is a patient, she is okay, but she's worried. You are FY2 in the GP, patient is 27, has come to you because she's worried about inheriting Huntington's disease. Her mother has been diagnosed. So Huntington's, what is it? It is an autosomal dominant condition, right? So first of all, how to manage these kind of stations? How can I help you? I'm worried I might inherit Huntington's disease because my mother has it. So now what you have to do in these kind of scenario is take a bit of history. Every station has got a little bit of history in the beginning. So what are the questions that I should ask? How much this patient knows about Huntington's disease? How much do you know? Because your mother has been diagnosed, so how much do you know about it, right? So because the thing is, we'll get a bit of idea what is the understanding of this patient. If patient knows half of it, I will give only half of information. If patient doesn't know anything, then I have to give too much of information to my patient. So it always makes sense to assess the knowledge of your patient, right? Then tell me more about it, like about your mother diagnosed, when she was diagnosed, how is she being cared for, what are the treatment that she is getting, how is she now, all those things. Now ask the symptoms, if this patient has got any symptoms or not. For example, like any involuntary movements, any coordination problem, any difficulty with the memory, mood, all those things you can ask. Now, we know it's an autosomal dominant. What is autosomal dominant disease? So it simply means, just a sec. So autosomal dominant, what does it mean? It means it's a genetic condition. If a parent has it, there is a 50% of chance of inheriting the gene. However, not everyone with the gene develops symptoms at the same age or in the same way. See, if a parent has got it, there are 50% of chances. That's clear. But maybe the mother has got this problem when she was 40. The patient might get it in the age of 30. It is quite possible, right? And the symptom which mother had, maybe the daughter is not having those symptoms. They might present with some other symptoms as well. This is quite okay. This is quite normal. I mean, so what I would like you to do in this, in most of these scenarios, don't only think about this patient, think about others as well. I mean, who else is there in the family, right? I mean, if you have got siblings or not, that is really, really important. And also, if this patient, Tracy, your patient, if she's planning to have kids or not. Because if she is gonna have Huntington's in the future, then she can actually give it 50% chances that even Tracy White, her children may also have Huntington. So what I would like you to do is whom you are living with, see if she has got any partners, see if she has got any children, if she is planning to have any children, if she has got any siblings or not. So these are the history points that you should be taking, because you are doing a kind of risk assessment for her kids in the future, and for her siblings as well. So that's something that you are doing, right? So the thing is, first of all, there is no cure. If you have to have it, you will have it, right? So medications that can be given, we can have the help for daily tasks as well. This patient can lead to have a problem with the dysphagia, and also eating support and all we can give. Now the genetic support, because if this patient is planning to have kids and her mom has got Huntington. So what we can do, referral to the genetic counseling to explain the process and support your decision. Regular check-in for physical and emotional support, that can be done. That should be okay, right? Options include genetic counseling, pre-implantation, genetic diagnosis, adoption, all those things can be discussed. Can we mention genetic testing while we are in the GP, or just refer to the patient for it? No, you can mention about genetic testing. That shouldn't be a problem. That should not be a problem, doctor. You can mention. Okay. General anxiety disorder, that's easy one. Menstrual migraine, you can easily manage it. Hyperemesis gravidarum, should it be a problem? Yeah, you will be having this, so you can go in detailing of it. Agranulocytosis, Carbimazole. Again, this station hasn't come for a very long time, but I think somebody mentioned, let's go a bit more into it. So the patient is mostly, you know that thyroid, you'll have a female patient. So patient is 40 years of age, has come to you with sore throat. She was started on Carbimazole, that is 3 weeks ago, for her hyperthyroidism. Right. So Carbimazole, what we need to remember, what are the side effects of it? Just remember one word, that is agranulocytosis, right? That's something that you can have. How can I help you? This patient says, I've got pain in my throat. So what you do a bit of Socrates. And obviously, when we have started any medication recently, and if patient has come up with a new symptom, we have to be very careful, because it might be because of the side effect of the drug. And carbimazole, we know, can cause agranulocytosis. So what are the questions I should be asking? If the patient has got any fever and chills, dizziness, and this patient can have a problem like pancreatitis as well. So you need to ask questions about like any tummy pain this patient has got, right? So that will be very important. And again, I would say use the information that is given to you in the question as well, that I can see that you've been diagnosed with hyperthyroid and you're taking a carbimazole. Yeah. So again, any fever and chills, any tummy pain you have got, any problem with the urine and color, urine and stool because of pancreatitis. So all those questions you can ask. Patient is female, so you can ask about LMP as well. That could be very, very important. And when you do the vitals, I would like to do general physical, check your vitals, and maybe the thyroid examination. The examiner gave you a finding, which is temperature is high. When you have got this, what is the thing? It is most probably going towards agranulocytosis caused by carbimazole, right? So the treatment is obviously stop the drug. That's the first thing. We usually admit these patients. Hospital admission should be there, and we may be able to start the patients on antibiotics, right? So monitoring and management for any infections or complications, and obviously regular blood test that has to be done. Now the problem is the patient has got this. Uh, Patient has got this infection. I mean, patient got this agranulocytosis caused by carbimazole. So we'll see if we are going to continue with this medication or we're going to change it. For now, you're definitely going to discontinue carbimazole, but we'll see if later we have to give maybe propylthiouracil or something else. But make sure you admit the patient and you start the patient on antibiotics, right? So that's the main thing. Right. So any station, if you get, just be careful if the patient has been started on any medication recently and now patient has come up with a new symptom, it's most probably going to be because of that drug only. So in this station, you need to talk a bit about maybe carbimazole. If the patient is taking it regularly as prescribed, then you need to talk about the side effects of carbimazole, which are agranulocytosis. Even if you want, you can talk a bit about the thyroid symptoms as well. You can talk about hypothyroidism symptoms as well, right? And that should be fine. Yeah, right. Lithium toxicity, again, that scenario we haven't seen for a bit longer, right? So, yeah, endometritis. Yes, this scenario has been coming up. So, what is endometritis? Endometritis, let's see. So the station is coming, you are FI to an accidental and emergency, and the patient is 32, has come with the tummy pain. Okay, so tummy pain, very vague statement, obviously. So how can I help? The patient has got tummy pain for last 2 to 3 hours. So any pain, what you do, you have to do the Socrates. So you'll get a bit of idea what this pain is all about, right? So it's a dull pain. Patient is taking paracetamol, didn't work. Now, anything else? The thing you got is patient had cesarean section 2 days ago, and my labor was prolonged for 30 hours. So remember one thing, endometritis is common when patient had a long labor. And a lot of patients, they present to us with tummy pain. It's infection. What is endometritis? It is infection of the womb lining. It can happen, it's common when patient has delivered with cesarean section or if the patient labor was prolonged, right? So that's the main thing, okay? Obviously, now you ask some associated symptoms as well. If patient has got any nausea, vomiting, any fever, flu-like symptoms, and urine, bowel, you can ask all those questions, right? And if the patient is still having any vaginal bleeding and all, you can ask those questions, right? I would like to do general physical examination, vitals, and pelvic swabs, all those things you can mention. And then what happened is this patient has got pain. So the diagnosis is most probably endometritis. Yeah. Now, what is the treatment? So, I have put it in a way that if the patient is feeling well or if the patient is feeling unwell, because the patient is feeling well, we may be able to start the patient on oral antibiotics. But if patient is not feeling well, then you need to admit the patient and you start the patient on IV antibiotics. That's the thing. Now, a lot of candidates will ask me, are we supposed to know the name of the antibiotics or not? That's really important. So, if you know, it's good. If you don't know, that is absolutely fine. Because you can always say, we'll be starting you on antibiotics according to the hospital protocol. It's fine. It's okay. It's not a big deal. Of course, if you're writing a prescription and they have said, okay, which antibiotic, in that case, you will have the time to open the BNF to find out which drug. But if it is a consultation, normal consultation station you're getting, and if you don't know the name of the antibiotic, it is not a big deal. Just remember that. Yeah. Otherwise, here we go for clindamycin, gentamicin, IV fluids, obviously, and we have to monitor the patient often, right? And hospital stay until the symptoms improve, and then we can switch it to oral antibiotics as well, right? Patient will always ask, in these scenarios, you will see your patient will always ask a question, if I can continue with the breastfeeding or not. So what do you think, guys? Breastfeeding is okay or not okay? Obviously, it's okay. Yeah, breastfeeding is always, always okay, right? And don't forget to give the warning signs and follow-ups. Again, one more thing, this patient is in pain as well. So which painkiller you are going to give? So on pain, we have got two scenarios. You must have heard a scenario which is coming in SIMMAN, that is post-CS pain management. Right. And there is another one, this endometritis. Obviously, you'll give antibiotics for treating the infection, but the patient has got pain as well. So you need to give pain management as well. Remember one thing. Can I give paracetamol? Yes. Can I give ibuprofen? Yes. The thing is, just remember, just ask one question, if she's doing breastfeeding or not. Because if she's doing breastfeeding, there is a drug which is contraindicated. Remember, codeine is never given if she's doing breastfeeding. So the alternate to codeine would be dihydrocodeine actually. So you must have heard a drug cocodamol. What is cocodamol? This is paracetamol plus codeine, which is not given if patient is doing breastfeeding, because cocodamol is meant to cause the maximum chances of neonatal respiratory depression. So you have an alternative. So instead of codeine, you will give dihydrocodeine. So the combination that you'll find in the market, instead of cocodamol, you have to go for codiadramol. that combination is okay. So can I give paracetamol to a breastfeeding mother? Yes. Can I give ibuprofen? Yes. Can I give dihydrocodeine? Yes. Can I give codidramol? Yes. Can I give codeine? The answer is no, no, no. If patient is in severe pain, can I give morphine? Yes, morphine is okay. As long as you're keeping an eye on the vitals of the baby, of the mother, that should be okay, right? But codeine is not at all given. Yeah. Mesothelioma. So guys, this station is coming in two different ways. Number one is patient had a fall. Patient had a fall. Patient was going somewhere and had a fall and was having some chest injury, and that's why we ordered the chest X-ray. Patient is around 60 years of age, and when we did the chest X-rays, accidentally we found something. What we found accidentally there, the patient has got bilateral pleural thickening, right? And this patient may not be giving you most of the things, most of the cancer questions positive. They may not give you, but patient is elderly and having bilateral pleural thickening. Please think about cancer only. Think about cancer only, right? Another scenario, this mesothelioma is coming. The patient is having dry cough. Later on, patient will tell you about hemoptysis as well. And this patient is a construction worker as well. Again, they're not giving much of cancer symptoms positive. And this patient, again, 60 years. So again, please think about mesothelioma only. So there are the two different ways this scenario is being coming in the exam. Okay. Dihydrocodeine is also contraindicated in breastfeeding. No, doctor, you can give it. That's what I'm saying. So, painkillers which are safe for breastfeeding mothers, paracetamol, ibuprofen, dihydrocodeine, codidramol, that's fine. These are okay to give. Codeine is not given. That's what I was trying to say. Okay, so mesothelioma, guys. So one is accidentally we found bilateral pleural thickening. We did an X-ray because the patient has got we did an X-ray because patient had a fall, but in the X-ray what we found bilateral pleural thickening, right? And another one is patient is having dry cough, then patient will tell you about hemoptysis, he's working in a construction. Sometimes they say, I'm working in asbestos industry. So it's mesothelioma. It's a breaking bad news, doctor. Yes, it is a breaking bad news. Yes, yes, yes. All right. So yeah, it's Down syndrome. So I think that you can easily manage. So NIPT and a combined test, you need to talk about it. So it should be okay. Essential tremor is okay as well. Cradle cap, we haven't seen for a bit longer. OCD, let's discuss a bit about this. So, in OCD, what they are doing, they keep on changing the history a bit. Last time, a few days ago, I think 2, 3 days ago, this scenario came. Your patient is a doctor, actually. You are talking to your junior colleague. You are talking to a junior colleague. He is an FY1 and he is having this OCD. What he says is like, I'm a bit worried. The reason is after seeing every patient, I just take off my gloves and I have to like wash my hands a few times. And then he will tell you that I am checking the logs for my home again and again. So he'll give you a lot of things positive, right? So they keep on changing the presenting complaint, but how can I help? So patient says sometimes I can't seem to get my work done properly. I feel anxious when I have to see the patients. And I have a fear that I might catch this infection if I go close to them. Okay. And also, patient also says, yes, I keep checking my door locks again and again, right? And do you feel these thoughts are excessive? Yes. Then in these scenarios, whatever scenario you get, after taking the history, I always advise the candidates to do a bit of depression screening as well. I always want you to ask for mood, anhedonia, how's their sleep, how's their eating, and your dear examiner is looking for a question, which is a suicide. If you have ever tried to harm yourself, ask these questions quickly. That will make your life easy, right? Now, what is this OCD? So, first, treatment is simple CBT, yeah? From what you have told me, you have got OCD. It's a condition where people experiencing distressing thoughts and they feel compelled to perform repetitive actions. So they have an obsession and they feel compelled to do those repetitive actions. That's what OCD is. For example, doing hand washing excessively. For some patient, just checking the locks again and again. So this is the thing. Now, what's the treatment? So what we do is we expose them to their obsession, but we make sure they are not doing the repetitive actions. And that is what is called as exposure and responsive prevention. So that's what we do. And CBT. If the patient is in severe situation, we might be going for some medications as well, but that's too much. First, I would advise you to go for CBT and exposure and response prevention. That should be the main thing. So you have to refer this patient to a psychologist and they will be able to manage it. Yeah. Okay. Medication overuse headache, guys. This station came, I think, on 14 or 15. And I know a lot of people, they made the diagnosis of tension headache. So be very careful. If any patient give you the history that have been taking the painkillers for 3 to 6 months and now presented with headache, think about medication overuse headache. Now tell me, so you will be obviously elaborating it, ruling out other differentials of headache as well that you can do. Now tell me the treatment for medication overuse headache. You have to stop painkillers. Are you going to stop them abruptly or you gonna step it down slowly, slowly? What do you think? Answer it. Are you going to stop it abruptly or you going to taper it down? What do you think? Abruptly stop PCM and NSAIDs, taper it down abruptly, opioids gradually. Okay. The thing is, you should be stopping them abruptly only. That's the best way to get the treatment done, right? Yes, if the patient is on opioid, patient is on morphine, patient is on codeine, cocodamol, in those cases, you might be tapering it down. However, if patient is on any medication for their migraine, patient is on NSAIDs, patient is on paracetamol, you need to stop it abruptly. That's much better. But the thing is, initially the symptoms might get worse because of the withdrawal symptoms and all, which is okay, which is fine, right? And slowly, slowly, you'll see patient will start improving, right? If withdrawal headaches are severe, we might be giving a short case or a short course of naproxen as well, right? So that's the main thing that can be done, right? But otherwise, the treatment is you have to stop them abruptly. However, if the patient is on morphine, codeine, you might be stopping it gradually as well, right? Acne, steroid-induced acne. I think it came 2 days ago. I'm going to share you the list as well, which station came. So don't worry. Advice symptoms get worse before get better. So doctor mentioned, yes, that's absolutely fine. And medication overuse headache, you have to give a warning sign to the patient that when we are asking you to stop the medications abruptly, the symptoms are going to get worse. So yes, tell the patient because of withdrawal symptoms. But then eventually they will start getting better, right? It's always good to give that warning sign. Agree, doctor, agree. Your FY2 patient is a 28-year-old male complaining of acne, right? Complaining of acne, talk to him and address his concern. So how can I help? The patient is saying, I'm getting a lot of acne these days and I want to get rid of it. We have got two scenarios. One, there's a female coming to you and asking for a medication called as oral isotretinoin. Tretinoin. And another is you have got this young gym guy who's asking for getting rid of this acne. So what I'm supposed to do with for that, right? So oral isotretinoin, whether patient has got moderate acne or it is severe acne, are we going to start the patient on oral isotretinoin? The answer is no. It is always and always started by the specialist. We cannot start the patient on this, right? Even if it is severe acne, we try going for a combined therapy. We go for, say, for example, oral antibiotics. We go for other medications, for example, yes, adapalene, like topical retinoids, we might be able to go for oral antibiotics. as a first line of treatment, even for severe acne. And if that's not making the things better for the patient, we'll be able to refer the patient to the specialist, and the specialist might be able to start the patient on oral isotretinoin Roaccutane, because the drug has got a lot of side effects as well. It's going to make your skin very thin and all. So that's why we have to be very careful. We are not the one who's going to start it, right? But this patient is not coming to you asking for oral isotretinoin. This is a new acne scenario they have got. So this patient is saying, I've been having acne for the last couple of months. You can ask like if the patient has got any bleeding coming, or what patient has already tried till now for acne. Right. And this patient will, if you ask if you are taking anything, this patient tells you, I've been taking some bodybuilding supplements, and I'm also taking a tablet called Dynabol. See, in the exam, he will not name this drug. He will say, I'm taking something die. He won't name it, but it's Dynabol. It's a steroid that this patient is taking. Right? Dynabol is an anabolic steroid. How long we've been taking it? Is taking it for last 4 months, right? So just be careful on this, right? Now, management is obviously doing a bit of a blood test and all. We can test that testosterone, LH, And what's the treatment? You have to stop anabolic steroids. That's the main thing. So whatever this patient is taking, what you have to do is you have to stop it, right? Benzoyl peroxide. This is something, Dr. Benzoyl peroxide, you will see in all those, what do you say? Face washes and all. So that is an adjuvant, doctor. Benzoyl peroxide, benzoyl, this is an adjuvant that can be used, but mainly it's a topical retinoids with antibiotics. It's a combination that we give. This benzoyl peroxide that can act as an adjuvant in the management of acne as well, right? So will my acne go away if I stop taking steroid? Yes, they will start improving according to the time, right? So yes, we need to ask the patient to stop Dynabol as well. For medication overuse headache, do we prescribe some other painkillers for headache or just stop it? We have to stop it, doctor. But if it is making the pain very worse, then if withdrawal headaches are severe, a short course of naproxen can be offered to this patient, right? That's the main thing. If the patient refuses to stop Dynabol, how we approach it? I mean, that's a treatment refusal, so I think you can manage it, right? So what you're going to say, you'll explain it to the patient that why you have come to us because of acne, and when you tell them the reason of acne is the drug that you're taking, so it's advisable you stop it, and when you stop it, you'll see this acne will start improving. That's it. So I think you'll be able to help them. Benefits are more, so I think they will be able to agree. Or else you can then check the understanding of the patient and see if the patient knows the implications of their decisions or not, right? Okay, what else? Epistaxis, nosebleeds, we haven't seen for a bit longer. Elbow examination, doctors, I have put it as a combined session, but uh, it used to come as a combined station, I think 8-10 years ago, but nowadays it's coming as a teaching station, but it can come as a combined station as well. Remember three things here. They might give you a station on tennis elbow as a combined station. They might give you a station on golfer's elbow, right? So, tennis elbow is your lateral epicondylitis and golfer's elbow is your medial epicondylitis, right? So they might give you this scenario. Till now, this station has come only as a teaching station, but can come as a combined station as well. So they'll tell you the pain either in lateral or medial side. So you'll be able to see if it is tennis elbow or golfer's elbow. Now, one question to everybody. If the patient has got both lateral and medial epicondylitis, then what do you think, which sports I'm playing or what is my occupation? Tell me. That scenario you will get in your exam soon. Any idea? Patient has got pain both medial and lateral epicondylitis. Yes, this patient might be a chef or this patient might be a painter as well. So just be careful, right? As I said, this hasn't come, but soon you will see it in your exams. So be careful. It can come as a teaching station, can come as a combined station as well. All right. Okay, somebody's asking salicylic acid for acne, doctor. That is also an adjuvant, doctor. It's an adjuvant, right? So adjuvant are not like I mean, it's definitive, but yes, the combination, the face washes and all we give, it has got benzoyl peroxide, has got salicylic acid as well as a kind of adjuvant. Yes. Okay, so domestic violence, homosexual cases. So this station, I'll tell you briefly. The station is coming in three, four different ways. So I've written one here. Your FY2 in A&E patient is 35, has come with ankle injury. He had visited the emergency department previously 3 times for facial injury, and he did the self-discharge. Talk to him, assess him, and manage him. So how can I help? He will tell you that I have I have injury in my right ankle. So I've got injury in my right ankle. So you will take a bit of history, you'll do the Socrates as well, but the patient has got injury and you'll say, oh, 1 week ago, but why did you come today only? Why didn't come 1 week ago? You'll take that history. Then you will bring up this point as well that you had this facial injury. Why did you do the self-discharge as well? And in this scenario, you will see lots of non-verbal cues are there as well. Lots of non. This patient is very fidgety. Patient is not giving eye contact, shaking his leg as well. So you need to offer some confidentiality as well. Let's see if this patient will be able to tell you a bit more, right? You may be able to ask HARK questions as well. HARK questions, I hope you know, humiliation, afraid, rape, kick. So you can ask those questions as well. Or else you can start with some general questionnaire, whom you are living with, how's your relationship, is everything all right at home, right? So all those questions you can ask first. And you will see they will be very hesitant in answering these questions. Offer confidentiality. At one point of time, they'll be able to open up, right? And then this patient tells you that I'm in relationship with him for last 4 years. And then he will start like, sometimes we have got ups and downs. What happened? Sometimes it gets scary as well. And he said he has pushed me a few times. He says like he's not working. I'm the one who is working. And he's controlling my bank balance as well. So that is something that we have got in this scenario, right? Then you can see like if there is any other person at home, maybe there is a child at home, maybe there's an elderly person at home. So you have to see like who are the victims of abuse here. Is it only this patient who has come to you, or there are other persons at home? They might be at risk as well. So just do a bit of assessment on that point as well, right? And yeah, and then we will do the management. So we can put you in contact with the designated person that we have got in the hospital, who can put you in contact with some other organization, mainly Marak organization. Again, if you know the name of this organization, it's okay. If you don't know their name, that's fine as well. So it's a multi-agency risk assessment conference, actually, Marak. So if you don't know the name, that is absolutely fine. GMC website says do not offer confidentiality straight away. So when is a good time to offer it? Yes, doctor, that's I always use this dialogue as well, that GMC website says do not offer confidentiality straight away. Yes. So what you do is you start the scenario, right? And you try getting the history from the patient, you try reassuring the patient, but then after a couple of minutes, you've seen patient is not opening up, or what history patient is giving to you, you know it very clearly that patient is lying to you. And then what you do is you will offer confidentiality, right? For example, when you see this scenario, it says patient has got facial injuries as well. Now patient is presented with ankle injury. You went into the cubicle and you saw the patient is fidgety, patient is not making eye contact, and you offered confidentiality straight away. Don't do that. So what I want you to do is take a bit of history on ankle, acknowledge those non-verbal cues, talk a bit about facial injuries as well. This patient is not opening up. Now offer confidentiality. So take a bit longer, take a bit of time. Try to reassure them in the beginning, and then only you will offer confidentiality. Don't offer straight away in the beginning, right? And whenever you say confidentiality, always say it's going to be between you and the team until everyone is safe. Don't say it's going to be between you and me. You and me, it's wrong. It can't be, because you're going to write it in the patient's file. That's going to be accessible to your colleagues as well. And you know, when it is not safe for the patient or not safe for anybody else, you might be breaching the confidentiality as well, which is also an option, isn't it? So that's why you have to be extra careful and make sure you're not lying to the patient. We are honest and transparent doctors. So the discussion that we're having is going to be confidential, going to be between you and the team until everyone is safe. right? So that's what you have to do. Now in this station, what you're going to do, the patient has come to you with the ankle sprain. So you'll do the management of ankle sprain as well. And you do the proper safeguarding of this case, right? Another thing, there is another scenario. The patient says, now recently it has come that it's a rape scenario and patient is worried about STI. How can I help? I'm worried about STI. Then you go a bit more in detail and offering reassurance, and maybe you have to offer confidentiality, and the patient will open up and will tell you that I went into my cousin's birthday party, his friends were there as well, I went out with one of his friends and I was raped, and then now he's worried about STI. So in rape sexual assault scenario, what happens is we can refer them to SARC center. SARC, it is sexual assault referral center. See, in the GP you may not have all the facility to do all the investigations for STI, for HIV. So what happens is, if you do some investigations now in GP and then you refer for the rest to the SARC, it may not make sense. So SARC, Sexual Assault Referral Center, they are specialized center which deals with these cases. So we usually refer them there, and they'll be able to do all the samples for STI if and they will be able to check for any other injuries if this patient has got. So that is the scenario you will see in the recalls, STI rape. So that is this scenario that's they are giving. Okay. Sick note, I think that has been discussed many times. Just remember one thing, guys, in the UK, the standard is for the first week, you can self-certify that I'm sick. You don't need to give any sick note to your patients. They can self-certify. But recently, this lady who wants a sick note, we used to tell the candidates that you don't have to give her a sick note. You can always say you can self-certify. But now she has changed the history a bit in the cubicle. What she's saying, I've already utilized my 1 week self-certification because I was feeling under the weather in the last week. I was having some, what do you say, runny nose and a fever. So that's why I didn't go to my work and I did my self-certification. And now my daughter has got chickenpox. I have to look after her. So I need a sick note. So you may have to fill this form in the exam. Okay. Oral thrush, this has not come recently and it's easy one as well. Kawasaki, yes, somebody was asking for Kawasaki. Let's, I've discussed it previously as well, but let's go a bit more into it. I would like you to differentiate in the exam if it is Kawasaki or if it is scarlet fever. So before I go into this scenario, let's have a look at the differentiating features actually. Kawasaki and scarlet. See, both of them have got strawberry tongue, so it may be a bit difficult to get the diagnosis. In the exam, they're giving us Kawasaki only. They have never given scarlet till now in our exam, right? So, okay, so Kawasaki, it's unknown cause. Possibly it's an abnormal immune reaction to an infection. Scarlet is caused by, it's a bacterial infection, as simple as that, right? Primarily children under 5 years of age, most commonly children between 5 to 15. So when you see the question outside the cubicle, check the age of this patient. That will be very, very important. Yeah. Key symptoms, fever lasting for more than 5 days. Here resolved between 3 to 5 days with antibiotics. Okay. Now this is swollen glands in the neck. Here in this, you may have swollen glands here as well. But remember one thing, swollen glands, but enlarged, painful cervical lymph nodes, but it is unilateral. It is unilateral. But here in scarlet, it's usually bilateral. So this is very, very, very important differentiating feature, actually, I would say, right? And it's not contagious, but this is bacterial infection, so this is contagious as well, right? One thing that's going to be very easy for you to diagnose. In scarlet, the picture is going to be like this. They say this rash appear like a sandpaper-like texture, like this one, right? Strawberry tongue you may have in both, so it might be a bit difficult to diagnose only on the basis of that. Now, if you have a look at this question, patient is 3, had got right-sided lymphadenopathy and a fever of 38. So patient is 3. So we said under 5 is Kawasaki. 5 to 15, more of scarlet fever. Ipsilateral lymph node swelling is Kawasaki only. So I think when you see this question, it's going to be very clear for you that you're dealing with Kawasaki only, right? So that's going to make your life easy. So child is unwell. So see if the patient is eating, drinking well or not. That's very important in the kids, right? And if the child is playful or not. Ask questions for meningitis also. That's very important. Any fever in the kid, you need to rule out meningitis, as simple as that, right? You need to ask the child is eating, drinking well, playful or not, and paracetamol if that is helping in his fever or not. Because we don't want a very high grade fever because patient might end up having febrile seizures as well. So we need to be very extra careful, right? Quickly, you can do the bird history and all, and then the management. So what is the management? So the management is simply, if it is scarlet fever, you give antibiotics. But this is not because of bacterial infection. So here the treatment is IVIG that is given, right? Now, one more thing. We always make sure we don't give aspirin. We don't give aspirin to the children under 16 because it can cause Reese syndrome, isn't it? But this Kawasaki is opposite to that. In the treatment, actually, you need to give aspirin as well. So what is the treatment? Treatment is aspirin and IVIG. And antibiotics are not gonna improve it. Antibiotics are not gonna improve it. So that's the thing. So Kawasaki Scarlet. Scarlet is 5 to 15 years. Kawasaki under 5 years. Ipsilateral lymphadenopathy. That's what you're gonna get in Kawasaki as well. Sandpaper appearance, rash. Who? Which patient? Scarlet fever. So few points. That's gonna be very helpful in differentiate. Okay. Perfect. Perfect. Okay. Another thing would be somebody asked me, so we refuse to give sick note, we don't fill it. No. So I think you're asking for the mother who's requesting for the sick note. I'm not refusing, doctor. So the task is you have to negotiate with the patient. In the end, if I am like, okay, I can give you a sick note, the standard in the UK that you don't need any written letter from the GP for the first 1 week. You can self-certify that I'm sick. So you can tell your employer that I'm sick. I'm not able to come. And you don't need any written documentation from the GP. And your employer will accept it, actually. That's what I was trying to say. So that's why you don't have to fill the form, right? You will tell her to self-certify. But recently what happened is they made some changes in this station and the patient says, I've already used 1 week of self-certification. In that case, you will be writing it for this patient. Okay. All right. Okay, so you're after in GP surgery, your patient is 26, has come for the checkup. Talk to her, assess and manage. So she says, and also the reports have been given to you that she's 14 weeks pregnant. The ultrasound reports that she is 12 or I think 14 weeks pregnant. That's given to you in the question, right? Then you will ask a bit of questions about her pregnancy, if everything is going okay. Have you attended previous antenatal visits or not? Any scans if they were done properly or not, right? Any symptoms of first trimester, any nausea, vomiting, any tummy pain, any breast tenderness, if you've got any vaginal bleeding, if you've got all those questions you can ask, right? Now, the thing is, this patient is actually, when you ask for smoking, alcohol, recreational drugs, she's doing everything, actually. She is doing everything, right? So that's the main thing here. You will talk about smoking, cannabis, and alcohol. I mean, what is the risk that your child can get if you are doing smoking, alcohol, and cannabis and all? That is easily you can manage. Now, the thing is, I have to be very careful in this kind of scenario. Please inform safeguarding team if required. This scenario revolves around that, right? So what we are doing, so I recommend stopping or reducing the smoking, alcohol, and cannabis use. These are the support programs available to help you in stopping smoking and alcohol and cannabis. And we can refer you to these programs because if you are doing smoking, what can happen? Premature birth can happen, low birth weight baby, breathing problems can happen, and the drugs can actually create problem with the baby's brain development as well, isn't it? So a lot of risks are there. So this patient is like, okay, I mean, she's ready to listen to you and she says, okay, I'll follow everything. But if you see lots of non-verbal cues, don't hesitate to involve safeguarding team, right? Okay. If she says that I don't a child and will continue smoking and cannabis, then what to do? You will explain the risks that your child can have. And I would advise to involve safeguarding team as well. Okay. All right. Hepatitis B, again, for the last few weeks, we haven't seen this scenario. What else? Infection, no, mononucleosis also we haven't seen. Contact dermatitis also we haven't seen. Okay, which one we should go with? Now let me discuss these three new stations which have come very recently. Yeah. Okay. And I'm going to send you this list as well. Don't worry, guys. Now, there was a station on a treatment refusal on the valve replacement. Your FY2 in cardiology, patient is Mr. Louis, age 76, was diagnosed with severe aortic stenosis. That was 15 years ago. And the consultant has advised for the surgical valve replacement, but the patient is refusing the procedure. Talk to him, assess, and address his concern. Straightforward scenario. So what I would like you to do in these kind of cases, how can I help you? Doctor, I don't want the surgery for my heart. And you're like, okay, what heart condition you have got? I can see from the notes that you've been diagnosed with a condition called aortic stenosis, and that was 15 years ago. And our doctors, our consultant has advised you to go for valve replacement. Am I right? Yes. Okay. So I just want to know if you've got symptoms or not. So you can ask some symptoms of aortic stenosis as well. I mean, if patient has got any shortness of breath, if patient is able to do his daily routine things, able to walk properly or not. So you can ask all those questions. Now, what you have to do, you can ask the patient if they are taking any medication, if the patient is taking those medications regularly as prescribed or not. Remember, guys, whenever you're doing the counseling and if patient is on any medication, you ask this question: are you taking these medication regularly as prescribed? Regularly as prescribed. And I would like you to ask one more question. By any chance, any missed dose or not? Ask these questions. Any counseling case, patient has come for the follow-ups and all, right? Then patient is refusing this treatment. So what you do, you will ask why. Why you don't want the surgery. That's the main thing. Then he will tell you the reason. The patient says, I don't want to have the surgery because my wife has Parkinson's disease. She needs help with everything like dressing, eating, even walking. And I'm the only one who looks after her. And if I go for surgery, who is going to look after her? What do you think? Is it a genuine concern? It is a genuine concern. And I would like you to acknowledge it. I can see that you have got genuine concern. I'm really sorry for your wife that she has got Parkinson. And I can see that you are the only care who is looking after her. Whatever patient says, try to reflect it back in the exam. That's the main thing. Acknowledgement of the patient's emotions. Whatever patient has said, if you reflect it back, you will see that it's going to be really helpful. It's going to be, and you will see the patient is going to be convinced easily, I would say. Right? Take a bit of history in the sense like which symptom of Parkinson she has got, but don't go into too much of detailing there. Right? And now what else you can do this is so you got the reason. Now what you have to do is you have to solve this. Now wife has got Parkinson's. So what do you think you can do for wife? So we can offer more help, isn't it? We can put you in contact with some organization who can look after your wife for the time being when you're going to go for your surgery, isn't it? So that is the main thing, right? So like, and then you will explain that benefits are more than the risks as well. Because sometimes he says like, when you're doing the surgery, if I die on the table, then who's going to look after my wife? But then you explain about this patient that aortic stenosis, when severe, it restricts the blood flow from your heart. It can cause a heart failure, collapse, sudden cardiac death. So surgery significantly reduces these risks and improve the symptoms and lifespan. When we are done with the surgery, you will see that you feel much better and you'll be able to look after your wife even much better way, right? And if patient understands, patient agree with you, it's okay. Otherwise, you need to check the competency level of the patient. You need to check if this patient has got understanding, if this patient has got the retention of information, and if this patient knows the implications of his or her decisions. It's his decisions, right? And then I would like you to ask about his mood as well, just to see he's not depressed. Also take a bit more psychosocial history. Who else is there in the family? Because what is his main concern? When I'm going to go for the surgery, who's going to look after my wife? So I would like you to explore. I mean, if there is anybody else in the family and friends. So maybe the family, your son, daughter, if you have got, he says, my son lives far away and works full time. I don't want to bother him. I make. So that's something that you can say, like, I know that your son is working and is working full time, but would it be possible for him to come for a week, maybe, when you're going to go for the surgery? He's the one who can look after the mother, I mean. And then once after a couple of weeks, you will feel better, and then you should be able to look after your wife. So that is what you have to do. In the end, if he agrees for surgery, it's okay. If he doesn't agree, that's fine as well. See, don't think if I'm not able to convince my patient, I'm going to fail this station. It's not going to like that. It's not going to be like that. I mean, maybe they have been instructed in a way that you don't have to get convinced today. So what they want to see, how much did you try? And also, did you check if this patient has got the understanding, retention of information? And the most important is if this patient knows the implication or consequences of his decisions or not. Okay, right, great. Now this one, a scaphoid fracture. So you are in A&E, this patient is Mr. Carter, age 34, has presented with sometimes shoulder pain or sometimes they will say a pain in the hand actually. Take history, assess him and discuss and the management, right? Okay, how do you check the patient's understanding? Okay, so doctor, in this, understanding, retention, implication. I'll ask a question to my patient that, so patient knows about aortic stenosis, patient knows what medication they're taking, why they're taking all those medications. The medications are there to help their symptoms and also we have done that part of the station. Now you'll ask the patient, so uh, Mr. Louis, if you don't go ahead with the surgery, do you know what's gonna happen to you? So what I'm checking if he's knowing about the implications or the consequences. He's like, I know that my condition might get worse, but I don't want to take these medications. Do you understand that? Yes, I do understand, and I have made my mind that I don't want to take this medication. So this is understanding as well as retention of information as well. So this is how I'm going to check, right? So you can start with implication and then you'll be able to check the understanding. Let the patient repeat things in his language. Yeah. Right. How can I help you? I've got pain in my shoulder. Sometimes they give the pain in the shoulder as well, but sometimes they give pain in the wrist area actually. It may not be shoulder, but maybe hand actually. It's more of a hand. Now, the patient says, I slipped and fell on my outstretched hand. You know, this history, falling outstretched hand. This is very, very, very important. The thing is, this patient is working in a construction company. He's working. He's on a ladder and he fell down on outstretched hand. This is a very typical history for scaphoid fracture actually. So when you ask a bit more like where exactly the pain is and all, so you're doing a full Socrates. He will tell you the pain somewhere here in the snuff box area, right? And do the full Socrates. And I would like you to ask if the pain is there in any other joint or not, any other part of the body or not, if the patient has got any fever, flu-like symptoms or not, any redness, swelling, any bruising, any sign of injury, trauma if the patient has got, and if the patient hit his head any time, any kind of dizziness, loss of conscious and all. So all those things I would like you to ask, right? And then you can take quick past personal history as well. If the patient has been diagnosed with any medical condition, any bone-related problem, any medication is taking, mainly taking steroid, for example, quickly, maybe smoking and all, because smoking will delay the healing of any bone, isn't it? So those questions you can ask, right? I would like to do general physical examination, vitals, and obviously the X-ray of the hand. Okay. So the symptoms, when you do ice, this patient might ask you, is it a fracture or I thought I just sprained it? See, X-ray, now, if the X-ray is going to give you the clear fracture or not, that is a thing. But, to be honest, the management won't be different, right? Because X-ray of the wrist, scaphoid view. So if the X-ray is positive, what is the management? The management is cast. orthopedic referral, and paracetamol, the analgesia that you're going to give, and then review this fracture after a week or so. If the X-ray is negative, but the suspicion is high, so what you do, you still go with the same management. You still go with the thumb cast, right? And then you repeat the X-ray after a week or two, and then if needed, we might go for an MRI scan as well. We don't go straight away because it's not very emergency, and it's not easy for getting a date for MRI scan straight away in this country as well. It takes time, right? So if it's positive, it's negative, you see the management is kind of same, right? But obviously, if it is displaced, then we have got for urgent surgical intervention and a surgical fixation, right? And the rest of the things will be like keep your arm elevated, painkillers, avoid using the hand until you are fine, and follow up with us, right? Complications that you can use as your warning sign, right? So, I mean, right? And that's it. I mean, so patient has fallen, outstretched hand, think about scaphoid fracture, as simple as that. Okay. If it is seen clearly in the X-ray or not seen in the X-ray, the management won't be different. It is same management only, right? And always advise the patient to keep the fingers mobile. That will be helpful in the healing as well, right? So this station has been coming, guys. Now, the recently another station has come, which is 6 weeks old infant. It's a heart murmur, right? So you are in GP. Patient is baby Ila, 6 weeks old, was seen by the GP, and the murmur was heard. And mother has some concern about the daughter. Talk to the mother, Miss Julian, and address her concern. Okay, so you start like, how can I help? And she's like that the GP has already checked my daughter, and she said, the GP said there is something that she could hear in my baby's heart, but then she didn't explain me properly, and that's why I am here to talk to you about like what's been happening with my daughter. Recently, this station, mother is not there, you're talking to father. I think this station came a day or 2 days ago. So not talking to the mother, you're talking to father. So it doesn't matter, right? So what do you do in these kind of scenarios? So a murmur was heard. So I would like you to do ask about the well-being of the child. I mean, how the child is doing. For example, if the child has got any problem with the eating or drinking, any problem with feeding, for example, right? Any abnormal breathing, if you have noticed, any abnormal sound when she's breathing. If you have any blue lip cyanosis, that's really, really important. If she is passing urine properly or not, and if she is increasing in terms of her weight or not, right? And if she's playful or not. If everything is okay, fever, if there is any fever, everything is fine. There is no fever, she's playing well, everything is fine. But sometimes the mother says, yeah, she's been crying a lot. But see, crying is not something unusual in kids and all, right? That you can see. And also, if the baby is crying and the murmur becomes a bit more clear as well. But when there is no other symptom the patient has got, this is what we call as an innocent murmur. So what you need to do, quick board history and all you can do as well. So in this, what you have to do is reassurance. Continue the feeding, weight gain is happening, general health is normal as well. So you have to nothing here. So clinical review, and we can arrange an echocardiogram, but it's not something urgent. You don't have to do anything on the urgent basis. You can explain that that what we have heard is a murmur, which is a sound made by the blood flowing through the heart. In many babies around this like 6-8 weeks, what can happen is we can hear these murmurs for the first time. Often they are innocent murmur, meaning they're harmless and they go away with time as the baby grows. Because your baby is feeding well, gaining weight, and seems active and well, that's very reassuring. So, but to be sure, we will refer you to the specialist, pediatric cardiologist, and they will be able to do a echo scan. That's the main thing. But don't forget to give the warning signs to her. What will be the warning sign? Like if there is any problem with the breathing, if you see like the swelling and bluish discoloration of the lips, for example, and child is not able to eat or drink properly. And yeah, that's it. And you just bring her back and we'll be able to, you can just take her to the hospital and then they will be able to manage her accordingly. Right. So in children, I mean, the fixed question, they are eating, drinking well, playful or not, and wetting the nappies the same way. I mean, any changes in that. So if all these things are fine, then there's nothing to worry. So that's the station that we are having. Okay. All right, guys. So yeah, that's the main thing. Now let's discuss. I mean, the station. I've got this list of the station. I'm gonna go through it quickly. And now, I'm hopeful that you guys are okay with the news chart. This news chart is coming again and again. So we need to know how to fill the news chart. So that has been explained in previous classes as well. Okay, so ninth. So I've got this list of stations. Let's start from the back actually, and that would be better. So, so do we have the news chart in the exam? Yes, doctor. In some stations, actually, they are expecting us to fill the news chart as well. Right. So, yes, 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 yes. Okay. How to fill it? No worries. I'll explain it to you. No problem. So on 21st, yesterday, this is the sun. These are the things. Breast cancer. That was easy one. Homosexual suicide, paracetamol. I think that's a very old scenario. Now examination I intracranial hypertension. Yes. So it's a station on idiopathic intracranial hypertension. Yeah. So, what we need to do in this, so this station is always coming with the eye mannequin, guys. The station is coming with the eye mannequin. The presenting complaint is a headache, and a headache mostly in the morning time. And also this patient says, I have got blurring of vision when I'm bending forward. I get blurring of vision when I'm bending forward. This is a typical history of intracranial hypertension, and the most probable cause is as well space occupying lesion. So this station, as I mentioned, is coming with the eye mannequin, and what you're gonna get in this is papilledema. So that's the scenario actually. Okay. Venus also asking for a referral as well. So the referral criteria is, that will be given to you in the questions in the cubicle itself. This patient is doing a job which is a long standing job. Sometimes they're saying I'm a it's a working in a shop, barber shop. So that's the main thing this patient is having. But the criterias for like when we go for the surgical interventions in venous ulcers, that is given, and the patient is not matching with those criteria, then you don't have to go for it. But you can advise the patient, as your job includes too much of standing, you advise the patient to take enough frequent breaks. Right, antenatal checkup, patient is having hypertension, and I think patient is on beta blockers. So you'll be starting the patient on a proper blood pressure medications. Febrile seizures, that is straightforward again, very old scenario. Syphilis, that's the old one as well. Innocent murmur, I just discussed. So that scenario has come 2 to 3 times in the last 2 weeks actually. MRSA, very old counseling scenario. Teaching cancer pathway. So, a lot of candidates ask me, like, when I have to teach cancer pathway, how should I teach? So, in every teaching, first is rapport building. You assess their knowledge as well. You ask them what exactly you want to learn, and all those briefing you can do. What you can do is you can take one of the example as well, and then you can explain. For example, you can take the example of lung cancer or breast cancer, and then you can explain this referral, right? So, how you going to get the cancer? So sometime how can you, I mean, the cancer pathways. So sometime it's a accidental finding. You can you can find the cancer accidental. Otherwise, mostly what we have got is the 2 weeks urgent pathway. 2 weeks urgent pathway. Any cancer, remember 2 weeks urgent pathway. However, if your patient is very young patient, so we might be going for very urgent pathway as well. See, okay, wait for this teaching cancer pathway. So what are the referrals, usual referrals we have got? So we have got routine referrals. We have got urgent referrals. We have got very urgent referrals. And we have got immediate referrals. What I mean by that? So for example, routine referral is routine, that you understand. Urgent referral is usually used for cancers. Very urgent is for cancer only, but the patient, for example, they are very young, under 25, for example. We have a station on testicular cancer. Patient is very young. We have a station on osteosarcoma where patient is 20 to 23. So in those cases, patient will be seen by the specialist within 48 hours. There's a very urgent referral actually. Right. Now, immediate referrals can be there as well. If the patient is not stable, that's immediate referral only, isn't it? Or many times you'll come across with the eye problems. For example, it's a scleritis or keratitis scenario. The patient is going to be in severe pain. So what's going to happen? GP is going to refer this patient straight away to the specialist. That is immediate referrals, right? So that is the thing that you can do. So routine referrals, urgent referrals, very urgent referrals, and immediate referrals as well. Okay. So that is, I mean, take an example of any cancer and you can explain that easily. Prescription was on VT prophylaxis, straightforward. Folliculitis, also known as Brazilian wax. So that was in dermatology, straightforward, very old scenario. It's there in our notes for a very long time. Cinven bleeding on warfarin, that's a very old scenario again. Sick note chickenpox, I just explained in this webinar. Psychosis, lot of people saying a scenario came on schizophrenia. No, it's not schizophrenia. For making the diagnosis of schizophrenia, patient should have the symptoms for at least 6 months. Our patient is giving the symptoms for 2 months only. How can you say it's schizophrenia? It's not, it's psychosis. Okay. And then we have got alcohol-related liver disease as well. In this station, they might be expecting you to do the examination, abdominal examination, where you will get what? What you'll get? Maybe abdominal distension. What else you might get? You might get hepatomegaly as well. So that's the thing. So that was yesterday, 21st. 20th, you get this anorexia nervosa. So we have got a lot of scenarios on eating disorder. You have got anorexia, you have got bulimia as well. Now answer a question. What is the admission criteria in anorexia nervosa? Remember one thing, guys. BMI is not the only criteria to decide the admission or discharge. You have to see other things as well. You have to see, for example, if patient is having insight or patient is not having insight. So that's really important. I mean, if patient BMI is, for example, say 17, we understand this is anorexia, but the patient is not having insight. So you can still keep the patient in the hospital. If the patient is not stable in terms of vitals, patient has got hypotension, patient is unstable, I will admit the patient. That is a different thing. However, otherwise, BMI is not the only criteria. So you have to see if this patient has got, if this patient understands the risk. So if the patient is competent enough or not. So you have to see other factors as well, right? So this patient understand that, yes, I've got anorexia, I have to listen to my doctor, I have to listen to my family members. So you may be able to discharge this patient and then call the patient for the follow-up, and then you can do the assessment. Right. Otherwise, if you see patient is not listening to you, not agreeing to you, you can keep the patient against their wish as well under Mental Health Act. So that is very, very important. So anorexia nervosa, bulimia, BMI is not the only criteria to decide the admission or discharge. Yes, if they're not stable vital-wise, you can always admit. But otherwise, think for other. If they are, if they've got medical capacity or not. Right? In anorexia, usually the BMI is low, whereas in bulimia, the BMI might be normal as well. Okay. Teaching station, inguinal-scrotal examination teaching, same medication overuse headache, we discussed. Endometriosis on COCP, very old scenario. AAA, abdominal aortic aneurysm. Guys, this station, I've seen a lot of candidates struggling. Remember one thing, in AAA, abdominal aortic aneurysm, the patient will give the history of back pain, and other symptoms. They may not give you any other symptoms, so be careful on that, because what are we expecting to have in other symptom? That patient has got a pulsatile mass in tummy, but the patient may not give you that history. Why? Because pulsatile mass is something that you will find on examination. Patient might have found himself, but he may not have found. So they may not give you that history. So what I'm trying to say, later on in the examination, when you say, I would like to examine you, would like to do general physical examination, vitals, patient has got back pains, he'll say, I will do the back examination. I would like you to mention abdominal examination as well. Because when you say abdominal examination, then only your examiner will give you the finding that they have got this pulsatile mass, right? And usually you will see this patient has got high blood pressure as well, and he's a smoker as well. So don't miss these points. Abdominal examination. Mesothelioma, I have explained. Down syndrome, we did that. Febrile convulsion, straightforward. Acute pyelonephritis prescription, that's easy. Steroid-induced acne, Dianabol, the patient is taking. STA with rape, that I explained. Hip fracture, cocodamol, that's easy. Hearing loss, lots of scenarios, guys, coming on hearing loss. So please make sure you are very thorough with it. I've got a detailed video on a hearing test. And hearing, I mean, what are the possible scenarios that we have got in the exam? So how to do it and what examination to be done in which station? I have made a detailed video, right? So just make sure you don't miss that. If you want, I can share that link as well, and you can go into detailing. So don't miss hearing tests, yeah? Then we have a station on angina, right? So teleconference, that's easy. So make sure you straight away send the patient to the hospital, send the ambulance, and the patient should be going to the hospital. Okay. Melanoma and measles, that's fine. And then now we have started exam on both street and as well as square as well. So for example, on 19th, we had the exam on street as well as square. So preeclampsia, 24 weeks. Yeah. So usually we have got two stations, guys, in the exam still now, that patient is having preeclampsia, and sometimes she is 36 weeks, sometimes she is 38 weeks. Right. So the management used to be different, because at what age of gestation we deliver the baby in preeclampsia? So number one, if there is any harm to the mother or to the baby, we deliver the baby then and there. Otherwise, if everything is under control, we will complete 37 weeks and then we will deliver the baby. So if it comes preeclampsia 38 weeks, what you do? You induce the labor, you deliver the baby. If it is 36 weeks, what you will do? You will try to control the blood pressure. You will do the assessment of the mother by doing all the investigation, blood test, make sure patient is not going into HELP syndrome, and you're doing the ultrasound scan as well, and you do something for the baby as well. You'll do the CTG, cardiac tachography as well, giving the medication for lowering down the blood pressure and checking the urine protein as well. And also, what are you doing is you will call your seniors to see if you have to give any medication for the eclampsia, for the fits. MgSO4 if you have to give, magnesium if you have to give. So all that is going to be the treatment. And then what you do, you will deliver the baby after some time when it is 37, when we have completed 37 weeks. So somebody's asking, will we admit the patient for a week? Maybe not, doctor. If it is 36, as long as everything is under control, then maybe we can be send this patient home. But we are going to call this patient and deliver the baby after completion of 37 weeks. So we may not be sending this patient home. But if the diagnosis of preeclampsia has been made, so if I'll admit for now, but I may not admit till the completion of 37. So maybe after 2-3 days, everything is under control. Now the blood pressure is under control. There are no urine proteins, baby is fine, mother is fine. So I might be able to send this patient home and then call again. That's what can happen. Now, preeclampsia, 24 weeks, that what happened. First of all, to make the diagnosis of preeclampsia, you need three things, guys. Number one, you need the age of gestation pregnancy should be more than 20 weeks. That's one. That we have got because it is 24 weeks. Second thing you need is a high blood pressure. That also we have got. And the third thing that you need would be patient has got urine protein. If you've got these three things, most probably it's preeclampsia. Because if they have only given 24 weeks pregnancy and they have given high blood pressure but no urine protein, it might be gestational hypertension as well. So you have to be very careful. But in our exam, what they have done, they are giving some presenting complaints as well. This patient has got headache. This patient has got slight tummy pain as well. So headache, tummy pain, and I would like you to ask more questions on preeclampsia. So what are the symptoms of preeclampsia? Headache, you have got blurring of vision, you have got nausea, vomiting, you have got tummy pain, you have got vaginal bleeding, you have got swelling in the ankle as well. So ask all these questions. Yeah, ask these questions, see what's positive. Yeah. And so in our exams, 24 weeks, she's having headache, she's having tummy pain as well. She's having high blood pressure, she's 24 weeks pregnant. So all criteria are going towards preeclampsia, but to confirm preeclampsia, what I'm supposed to do? I have to have urine protein as well. So they have not given, but if you ask for it in the examination investigation, they are gonna give it to you. They are gonna give it to you. And then you can diagnose it saying preeclampsia, and the management is you have to do something for the, I mean, you have to ask question for the baby, you have to ask question for the mother as well. So you're asking all these symptoms for mother. You can ask also if you're able to feel the kicks of the baby and all. So that is very important, because whenever you get a station on pregnancy, in the late pregnancy, any station, you don't have one patient, you have got two patients. You have got the mother, you have got the baby as well. So you're asking so many questions for the mother. I would like you to ask something for the baby as well. Maybe are able to feel the movements of the baby. So that is gonna be very, very important. Yeah. So, yeah, so that's the station. So you need three things: more than 20 weeks of pregnancy, high blood pressure, and urine protein. In our exam, they have been giving us high blood pressure, 24 weeks pregnancy, and they're giving some symptoms like headache and tummy pain, going more towards preeclampsia, but please do urine protein. And then do other investigation for help as well, do an ultrasound scan as well, and do a CTG as well. Do all those things and keep the patient in the hospital. Am I going to admit? Yes, I am definitely going to admit, because it's her first pregnancy as well. And first pregnancy is a risk factor for preeclampsia, actually, right? So, yeah. Obesity counseling, it's a pre-op. So yeah, we are saying the guidelines are given at what BMI you're going to go for surgery. So that's their skin cancer, Kawasaki, DK treatment, patient is refusing the treatment. So you need to convince her to stay, because how you can convince the patient to stay, you have to tell that we have to give you IV fluids. We need to monitor you. So that's why we're going to keep you in the hospital. And why she's refusing the treatment, she always says that I have to pick my children from the school. So I think that can be managed by somebody else, right? Hypertension, semen asthma, MMR causing autism, leukemia. The blood test shows WBC count of 40,000. Patient went for well-man checkup. So yeah. Epilepsy follow-up, OCD, trophic vaginitis, hearing loss, UTI prescription, mesothelioma, prostate scenario. So all these are like very common scenarios that you can easily do. What do you do for preeclampsia in the management? So I'll be giving some medication for reducing the blood pressure, doctor. Okay, so first of all, investigation. For the mother, for the baby. For the mother, what I'm going to do, I'll be checking urine protein. I'll be checking keeping an eye on the blood pressure as well, and doing the routine blood test for help, for hemolysis, for um, elevated liver and low platelets. So I'll be checking all those routine blood tests as well, and doing an ultrasound scan as well. For the baby, I'll be doing an CTG as well. For the treatment, I'll be giving the medication to lower down the blood pressure. And I'll call my senior as well. We might be able to start this patient on the prevention of the complication, which is eclampsia. So might be giving a magnesium as well. So that's a treatment, keeping the patient in the hospital. Right. Okay. So how do you say CTG? It's just a scan for your baby, I'll say. Scan for the baby, just to check his well-being. So we'll do a scan for you to check your well-being, and for your baby's well-being, we'll do a scan. We'll just put a device on your tummy, a belt on your tummy, which will record the activity of your baby, and that's what we want to do. That's it. If the child is unconscious with trauma and needs life-saving blood, parents are Jehovah Witness and refuses, what do you do? You do what is in the best interest of the patient. Okay. Yeah. Hip fracture and admission, endometriosis, chronic fatigue syndrome, skin cancer, angina, febrile convulsion, anorexia, inguinal scrotal teaching, Down syndrome, 16-year-old abuse, acute pyelonephritis, abdominal aortic aneurysm, hearing loss, acne, measles. So same, isn't it? Blood or no blood? What is needed, my friend? So we have to see a lot of things. So if they are saying Jehovah Witness, so what we can do is, if blood is really needed and that's the only thing that is needed to save the patient, so yes, I will give the blood, right? In the hospital, you should not take that decision. First of all, you are FY2. Do you think you'll be taking that final decision? Not really. Also, we always have a legal team in the hospital as well. Please involve them in the scenario as well. So later on, you will not be in trouble. That's the thing, right? So what happens is like we respect their religious beliefs and everything. So what we might be doing, we can see, we can ask the parents, for example, if they are okay with the, for example, fluids, if they're okay with the blood products, maybe. So many times you will see the problem in the Jehovah is with the whole blood, but they don't have problem in blood products. So that is something that you can ask, right? Another thing. Parents, anybody. If it is a life-saving thing, they have got limited rights as well, right? So it's what is a gilly competency. So we have to see a lot of things on that. So you said that child is unconscious. So if we think blood is the only way to save this patient, so I'll involve the legal team and we might be able to give the blood, right? But don't think in that too much into, they won't give you that kind of extreme case doctor in PLAB 2 exam, right? So that should be fine. Yeah. Okay, so this was 19th, and this is before 19th. We had exam on 16th. So these are for 16th as well. So bulimia, whiplash, herpetic whitlow, speculum teaching, endometriosis, TIA, essential tremors, acoustic neuroma, pneumonia, night terror, post-op infection counseling, performance anxiety. So guys, this performance anxiety scenario nowadays coming with the testicular examination, and where testicular examination is actually normal. So don't get anything wrong there. Chickenpox and pregnant lady, postural hypotension, PE, back sprain. Here you got elderly fall, wrong axis. It's a medical error, hyperthyroidism, febrile convulsion, some somatoform, syphilis, rivaroxaban prescription, oral candidiasis, meningitis, tinnitus, polymyalgia rheumatica. Unilateral tinnitus, guys, coming again and again. If it is unilateral tinnitus, please do an MRI scan for acoustic neuroma. It's a red flag. Angioedema due to ramipril. We used to have this scenario that patient has got dry cough because of uh, ACE inhibitors. And nowadays, I don't know, every other day they're giving a station, patient has been given CCP, calcium channel blocker. And because of that, patient is coming with the swelling in the legs. So very commonly it's coming. Yeah. Palpitations, elevated PSA, idiopathic intracranial hypertension. Again, I don't know this station, why it's all the time it's coming. What comes in syphilis? Patient came with the ulcer. Yes, doctor. Patient says, I'm embarrassed to talk. So for a minute, you have to offer some like reassurance and all. Then he'll open up and then he'll say, yes, I've got ulcer in my private area. And the riluzole, that's done as well. Before 16th, we have got the exam on 15th. So that was on 15th, phlebotomy teaching. So guys, all of you, I would want to say one thing that in phlebotomy, in the blood sampling, be comfortable how to do the blood sampling with the butterfly needle, because in this scenario, they're always giving us butterfly needle. So yes, be comfortable in that. Right? HIV, lymphadenopathy, epilepsy, annual review, prostatitis, DRE, COPD prescription, metformin-associated lactic acidosis, osteoporosis treatment, antenatal check, preeclampsia. So that's the one we discussed. Patient is worried about dementia, OCD, urticaria, daughter diagnosed with depression. So the thing is, daughter is diagnosed with depression and you're talking to father, and father is saying that my daughter has left the job but she didn't tell me. Would you like to do something on that? But the thing is, it's confidential. We cannot give any information to the father in regards to her daughter. So you have to talk very much in general in these kind of scenario, right? Tension headache or medication overuse headache. So when we spoke to the candidates, we were a bit, the candidates were not sure which station was it, but it was medication overuse headache actually on that day. Kidney stone, stress incontinence, Morton's neuroma, right? DRE is contraindication in prostatitis. The thing is, you can do it, doctor. It's not contra. It's not like absolute contraindication. Here, patient is having. Patient says pain in the anal area. Patient says I've got pain in the anal area. Patient use that word anal area. Sometimes patient says I've got pain down there, and they have got a couple of symptoms for. Frequency as well. Patient is not that old, like we'll have a lot of prostate symptoms and all, but couple of symptoms like as a frequency and all they have got. And when you do the examination, that can be done, but this patient has got pain. So that's how you diagnose it as a prostatitis, and make sure you give painkillers and you give antibiotics as well, right? So yes, you can proceed with the examination, doctor. And the square, the stations were the generalized anxiety disorder, tired, abdominal examination, fit note, uterine fibroids, frozen shoulder. Frozen shoulder, have to do the examination on the patient. Yeah. And the vaccination, always this question comes to me that uh, will the vaccination chart is gonna be given to us in the cubicle? Yes, they always give us vaccination chart in the cubicle. But are they gonna give us the milestone chart? They don't give us milestone chart. So make sure you remember the milestones. But vaccination chart will be given to you. Right. NI spiral fracture, ARMD, lithium prescription, ectopic pregnancy, morphine toxicity, man, female catheter teaching, mesothelioma, and there is a patient says, don't discharge my mom, folliculitis, Huntington. I think it's the same, guys. I mean, there is nothing new. I have got this list. I'm going to send it to you. So it's from 9th, 10th, and then 15th, 16th, until 21st. I've got this stations, right? So, I mean, I've got everything. So I'm going to send it to you. There's no point in discussing. And whatever important was, I have already discussed, right? Morphine toxicity, man. So morphine toxicity, doctor, it's given in the question that patient is on morphine. And the findings that you're going to get when you do the examination, when you check the vitals on the monitor, patient respiratory rate is very low. It's 6. And also patient has got, when you check the pupil, it's like pinpoint pupil. So in the beginning, in the breathing, when you find this, you need to start treating the patient. You need to give the management then and there. Okay. Do we need to send a blood test for morphine level in the SIMMAM case? Not really, not really, no. Mass in anterior wall of vagina with stress test positive. What is it, doctor? I mean, I didn't understand your question. Urges bladder retraining, stresses pelvic floor exercises. Yes, correct. Okay. A recent case, mass in the anterior wall of the vagina with stress test positive. I think that station is not a recent one. If I'm not wrong, that's a fibroid station. Are you talking about the fibroid station, doctor? There also they have got it there. Is it the fibroid case, Dr. Hassing? If I'm not wrong, the station is not a recent one. It's a very old one. It's there for a few years now. Some said cystocele. Which date it is? Because in the recalls, it wasn't there. Cystocele. I'll check it out, but I'm not sure. Uh, today. I mean, today's scenario I don't have because we prepared till because the webinar was there at 6 o'clock. So we had the scenario till yesterday. If anything came today, uh, I don't have that thing, and I'll update you next week, maybe. Yeah, but I'll check on it. Cystocele, I have put that in my list. Some said it's UV prolapse. UV prolapse is a very old scenario, my friend. It's there in the books for a very long time. But if it is there, if there is anything new, cystocele or something, give me some time. Yeah, we'll manage it. What's the management for urge plus stress incontinence? Okay, it's easy, doctor. You can go for bladder retraining and then pelvic floor muscle exercises. Yeah. Okay. Good. Anything else? I've written, doctor, this cystocele one, and I'll see. I'll do a bit of research and we'll get back to you on it. Yeah. Okay. Any other thing? What is CFS? It's a chronic fatigue syndrome, doctor. If patient is unresponsive in some man, should GCS be assessed before accessing airway or during disability? It's only on disability, doctor. First you check airway, breathing, circulation, and then only GCS. It should be going in sequence only, right? Osteoporosis treatment. I mean, it depends, but Dr. Bisphosphonates can be given. No, but mainly in that station, you might have to do the bisphosphonate counseling actually. Right. So like empty stomach, a glass of water, don't lie down. So that's the main thing you need to. And then you can advise the patient for strengthening exercises as well. We can refer the patient to a gym instructor and all. They'll be able to help the patient out with the training, and also on the diet and all, encourage the patient maybe for dairy products and all. Yeah. Is there no same day referral? Yes, we have no, like I explained, like keratitis, scleritis, and all that is kind of like the same day, immediate referral we have got. Yeah. Okay. Hmm. Right, guys. So that's the main thing. I just want to know, how many of you, do we have anybody who's not from Aspire, or all of you are Aspire students? Tell me in the chat box. Okay, so most of you are Aspire candidates. Good, 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 good. Not from Aspire yet. Okay, not from Aspire. Okay, some of you are Aspire, some of you are not. Okay, so those are Aspire candidate. Good. Those who are not Aspire candidates, I just want to explain, if there is any question that you have got regarding our academy, I mean, what we guys do, how it is done, what are the courses, and you can ask me if you've got any question. And I would advise you to join the WhatsApp group as well. That's the QR code. Please come and will be. And if you've got any question regarding the course, we will be able to answer your questions there in the group. And doctor, if you have 2.5 months in the preparation, that should be fine, doctor. 2.5 months is good actually. Yeah. And a lot of candidates, those who are not able to book the whole course. So we have got a small course package as well for you guys. For example, you don't want the in-person classes. You don't want the mocks. What you want is our online course. Online course means it's a full course, online live telecast, 12 days online live telecast, plus the supervised practice in the academy. If you want to join only that part, you can join it. It's 249 pounds only if you wish to. Another thing, if you want to join only the supervised practice with one mock, you can do that as well. That's in 199 pounds only. If you want to have any personalized session, if anybody wants like online mock, we can arrange that as well. And we'll be able to give you more information if you come in our WhatsApp group. Yeah. Do you have any course for 2 to 3 days, especially for SIMMAN and examination? So what happens, doctor? For example, I've got two courses for you, 2 to 3 days. So what happened is every week we have got the whole syllabus done. So we have got 12 days courses, that's separate, but you want only for 2 to 3 days. So what we have is, I would advise not to 2 to 3 days, but I would say you can join for at least 1 week or maybe at 5, 6 days. So what happened is in the academy, for example, on Monday, we have got hands-on mannequin supervised practice. Then maybe on Tuesday, we have got prescription practice. Maybe on Wednesday or Thursday, we have got SIMMAN session. Then we have got some ethical and history station practice. So this is the way we do it every week actually. So if you ask me any course for 2 to 3 days, not 2 to 3 days, but I've got for like 5, 6 days, which will cover everything. And it's a supervised practice for SIMMAN, for examination, for mannequins as well. And with one more if you wish to. So that can be done. And you'll have the access to the academy and you can practice on the mannequins and all. And if you don't want the mock, you want our online live course, that's for 12 days, full PLAB 2 course with the practice in the academy, with these supervised sessions, that can be, you can avail that as well. How many weeks is advisable to spend in the academy? Good question. I would advise to spend at least 6 weeks, 6 to 8 weeks, we say, right? And yeah, and depends on person to person. Yeah. And also, if possible, join our Telegram group as well. The link has been shared in the chat. Because in Telegram we update all these recalls, and you can access the recalls for the whole 2 years in that Telegram group. So if you wish to join, that's good as well. And how can we plan 1 month before exam? So we have done a detailed webinar on that, doctor. I'll tell you briefly. So if you've got 1 month, so this 1 month, Dr. Hina, so you are in the academy and then you're asking me, isn't it? So I would say, first of all, make a group of 3, 4 people. That's the main thing, 3, 4 person in a group. and make a plan that tomorrow we're going to practice these 30 to 40 stations, some from medicine, some from counseling, some from ethics, and then examination, mannequin, couple of sim, and two prescription. So in the night, maybe you read a bit about it, and the morning, those three, four people sit together and practice. So if you do this thing into 10 days, same thing, if you apply, you're done with the whole syllabus in 10 days. And then maybe change your practice partner and repeat the same thing again. And then you give the mock as well. And when you give the mock, you will see where I'm good, where I need more practice. So you can spend more time there. Give another mock, see where you have improved and where you are lacking. So that would be the advice, right? So that's something you can do. Anything on Sunday? Anything on Sunday? Why anything on Sunday? Not really, doctor. So the webinar is going to be next week. We will announce soon. In the academy, till what time do you have the practice sessions if you don't live in the academy? So the practice session, doctor, it depends. First of all, it depends on if our regular classes are happening or not. But for example, like hands-on mannequin session, it happens in the morning at 11:30. Prescription session happens at roughly 5 o'clock. Simman, it happened today actually. So it was at 2 o'clock. Right. So yeah, some are in the morning, some are in the afternoon. So what we do is we have got announcement group and we will post the whole week schedule in a poster. And then every day we will send you a WhatsApp message that today's session on this time, tomorrow's session on this time. So it's there actually. Right. What is your QR for Telegram group? We just send the message in the chat only, doctor. Or if you come in the WhatsApp group, I can share that with you, right? If you come in the WhatsApp group, I can share the contact details for the Telegram group as well there. Could you please send this PDF? I'm going to send in the WhatsApp group, doctor. Once I just close this webinar, I'm going to share it straight away. Yeah.